نحمده ونصلي على رسوله الكريم. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. Thank you for being here. And I think I was remembering when I was here like 5-6 years ago, and we used to have these research days, research symposium, and basically it was, I think usually it was a 2 days event. The first day was for the faculty and the second day was for the students. But I feel quite comfortable and happy and proud to be part of a group of students who are presenting. So I will take just, should I start? Okay, so the idea of this presentation is basically to highlight the fact that the lifestyle-related diseases in Saudi Arabia are a big threat, and is basically the main purpose of the health system should be to control and prevent these diseases. Okay, so essentially we have two things which are responsible for the emergence of non-communicable disease in Saudi Arabia. The first is the demographic transition, in which we have more elderly people and fewer younger people now, because I will show you a slide how this is happening. The second one is an epidemiologic transition, and so in this scenario, I think the NCDs is the big purpose. The primary healthcare system essentially should be taking care of the primary and secondary prevention of NCDs, which in my view is lacking in some ways, and we can look into it. How did I collect the data? Basically, I used primarily the Saudi Arabia Health Interview Survey, which was done in 2013. So it's a little bit old, but I hear that there will be another one very soon, maybe this year. So we'll have a comparison. I also looked at about 7 different other articles which were about health systems and about the epidemiology of non-communicable diseases in Saudi Arabia. So this is the presentation. I start from the findings of the Saudi Arabia Health Interview Survey, and then followed by some suggestions from the literature which was published by Saudi scientists and researchers. So Saudi Health Interview Survey 2013 was a multi-stage representative sample, and adults of 15 years or older were interviewed in all households they were visited. And the survey was conducted in all the regions of Saudi Arabia. The sample size was according to the size of the region and the cluster. And this estimated the prevalence of risk factors also, and the NCDs themselves. Included physical examination and lab examination of blood samples of the study participants. So quite an in-depth and wide-scale survey. I start with this population pyramid just to have a look at, if you look at this 60 to 64 age group, the sizable number of bars. So altogether, there are about 2.5 million people who are 60 and above in Saudi Arabia, which is almost 10%, I think, of the Saudi population. So not including the non-Saudi population residents. This is the demographic transition. It's like a picture where you have seen the crude birth rate is going down sharply, and crude death rate is also going down sharply. So it's basically at the beginning of the 4th stage, where you will have very low crude birth rate and very low crude death rate. What will be the effect? The elderly population will increase, the younger population will decrease. This is the epidemiological transition, only a model. I could not find actual data, so I just looked at some of the models. What is happening since 1950, between 2000 and until 2017? The prevalence of infectious disease has come down very rapidly. and the prevalence of NCD is increasing gradually. So this is basically crossover somewhere around 2000. And then this is the results from the Saudi Health Interview Survey, 2013. And you see here is the prevalence of obesity and overweight. And among the males, it's 24% and 33%, respectively, and among the females, it's 33%, 28%. So pretty high. It's all ages, 15 and above. In this slide, we're showing all the BMI over 30 between two age groups, 15 to 24 and 55 to 64. So basically, in the males and females, you see a slight difference in 55 to 64, but not in 15 to 24. So this is alarming that a very younger age group, it still has about 13 to 14% of overweight and obesity prevalence. And then this is the prevalence of hypertension of people who are age 45 and above. So in the males, you see that basically the youngest age group is the youngest in this age group, like 45 to 54, is 35.3% to 48.3% to 68% almost. And then females slightly lower than males, but so this is like, generally people probably know quite well. But this is what is alarming, that the Saudi Health Interview Survey actually found a lot of people who are undiagnosed. So among the diagnosed, among the people who are having hypertension, in the youngest age group among males, 62% were undiagnosed before. Among the females, 55% were undiagnosed before. So they were first time diagnosed by the survey itself, which is very alarming. And especially in the highest age group, 65 plus, you see still there are 39 and 32%. How could it happen? Like if they are visiting a health facility, then they should be taken blood pressure regularly, routinely, as they were not diagnosed. Second alarming thing was the uncontrolled hypertension. Again, the same survey. And you see that these are the patients who were identified and being managed for hypertension. Still, their hypertension is not controlled. And problems could be compliance and, regular visits, lack of healthy lifestyle, etc. But if you see in the youngest age group, 16%, and highest age group, about 39% of the males. Slightly less in female side, but about the same. So this is something like a red alert. Similarly, for prevalence of diabetes in the age 45 and above, they found 30% in the youngest age group in 45 to 54 and males. And so everywhere actually females have slightly lower prevalence rates than the males. And similarly, as hypertension, undiagnosed diabetes, which was not diagnosed before, and that was basically, again, of all the diabetic patients which they were reported in the survey, about a quarter of the people who were under, in 45 to 54 years of age group, were not diagnosed before. And this prevalence was higher, this proportion was higher among the females. Then you look at the uncontrolled diabetes in a similar fashion as hypertension. These are the diabetic patients who are diagnosed and being treated and managed, but their diabetes is not under control. And this is again 45 to 54 years of age group, about 22%, and in the females is much higher, about 41%. So this is something also a red alert that, Then finally, this slide for pre-diabetes percentage. So this was defined as HbA1c level of 5.7% to 6.5%. And this is under age 45, of course, so you see that again 12% in the youngest age group, 15 to 24 years age group, 13% in both male and female, and about 22% in the 35 to 44 years of age group, So these are like pre-diabetics who can be easily managed and prevented from going into frank diabetes. This was actually one thing which also reported in this survey, was that They asked, like, when was your routine medical checkup? Routine is like when you don't go for any disease or any symptom, just for a routine medical checkup. And this is for the people who are 45 years and above. So you see that about 30% here altogether, between 20 and 30%, they did go for a routine medical checkup who was 45 and above. And no other details were available. Maybe they went for a employment medical test required for employment or something, but they did go for a routine medical test. Okay. I need like 4 minutes only. I'm sorry. So this is simple, like, health facilities in Saudi Arabia. Almost one health facility of any kind for about 11,000 population, which is pretty good. 2,300 primary healthcare centers and other government hospitals. And this, we also have a Vision 2030, and under which we also have a National Transformation Program 2020, which calls off the improve the quality of PHCC and all that. So I am suggesting, based on the literature which I reviewed, a 3D prevention strategy with the following elements: the health promotion, primary prevention, secondary prevention. And this slide actually explains that you can start with a health promotion which has health education, and then it's followed by screening and then patient compliance and family support. So it goes down to the secondary prevention. And the other side is the risk management, also as a primary prevention, and giving the health incentives for continuation of the treatment or management of the diseases. So this is something. Health promotion, you can use electronic social media, screening campaigns. For focused primary prevention, you can also have like health education for family members of diabetics, and especially if your mother is diabetic, you should be concerned about that you will also get diabetes. Screening for NCD should be a part of the, I think this should be something which be given a priority in the primary healthcare centers, routine screening for NCDs. Improved patient compliance. Saudi Arabia has health passports for children where vaccinations are recorded. So literature actually suggests having similar, something like that, for NCD patients who along the same lines to control their disease. And targeted secondary prevention, basically, mobile apps to continue medical appointments, to lab tests and continue medication. And then I think given some incentives, because in the future, Saudi Arabia will have to bring in private sector, and the free healthcare probably will not be available as freely as it is now. So subsidies and discounts in medical insurance and for compliance, this will be incentives for maintaining your health. And reorganizing the primary healthcare system would require special training for doctors and nurses, and regular sessions of health education. So in summary, the prevalence of diabetes, obesity, hypertension is on the rise and is alarming. The health system is lacking the efficiency in early diagnosis of the NCDs, as well as the patient compliance is poor. And the health system, particularly the primary healthcare center, should take the responsibility for health prevention and disease prevention. Thank you, sir.
Our study, in agreement with the research conducted by Minkumari et al. 2018, also reported the same result favoring the use of backfill composite because of their better property and improved placement than nanohybrid composite. However, we don't have came across even a single study that bulk fill composite are inferior than nanohybrid composite, thus making a case for more research to be done in future. In conclusion, the nanobulk fill composite are superior in property to nanohybrid composite and can be used in all types of restoration. These are the most important references that I used. That was the end of my presentation. Thank you for listening. Any question? Okay, thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Every research has a problem or research question to solve or to find out what's beyond these problems. Our research problems become from a short story regarding Ziad and Yazid. Ziad and Yazid are from two different families. Both of them are 3 years old. And both of them complained of they move a lot, hyperactive, and they complained of delayed speech. The Ziyad family noticed his symptoms early and went to a psychiatrist, and they treated him, and he started to speak, and then went to a school where he was partially normal as any other kids. While Yazid family, they didn't notice his symptoms. They considered it as normal, and they attributed to phones or iPads or any other reasons. So he went to school and started elementary school undiagnosed of having ADHD or attention deficit hyperactivity disorder. Then later on, he was hyperactive in class, moved to from his chair, had many misbehaviors. Teachers were punishing him for his misbehaviors, and later on he complains of depression and difficulty in learning. So this comes as we have here two stations to diagnose attention deficit hyperactivity disorder. First of all, from the parents. The second station from the teachers. Here we come from the importance of teachers. Studies said that 40% of ADHD cases are diagnosed from teachers. And this is a big number. Also, as a part of the diagnostic process in the clinic, both teachers and parents have to be interviewed as part of the diagnostic process. So imagine if Yazid was exposed to teachers who were aware, they know the symptoms of ADHD. That would change his future, and he would be, you would have no difficulty in learning. Remote. طيب بسم الله. First of all, regarding ADHD, what is ADHD? ADHD is attention deficit hyperactivity disorder, is one of the most neurodevelopmental disorders that affects children. It is persistent and exhausting inattention, hyperactivity, and impulsivity disorder. The prevalence in Saudi Arabia in a recent study was 3.4 among our children. So, it is associated with difficulty in learning and occupational underachievement and poor family and peer relationship. Also, it is related to substance abuse later when these cases are worsened. So, as I mentioned before, 40% of the cases, of ADHD cases, are diagnosed from teachers. This highlights the importance of teachers, and also both of the teachers have to be, both teachers and parents have to be interviewed or asked about the kid as a part of diagnostic criteria or in the clinic. However, the vast majority, studies say that the vast majority of teachers have neither the understanding nor the enough knowledge about ADHD. So we aim here in our study to examine or explore the awareness regarding of teachers regarding ADHD and to compare it with various characteristics. There is a study said that using heterogeneous sampling would be better than homogeneous sampling. So we used a cross-sectional survey using stratified proportionate random sampling, and we carry it in the schools of elementary and kindergarten schools in the largest 4 cities of Qassim region: Breda, Aneza, Arras, Al-Kariya. The total population of the sample was more than 16,000. And our sample was 988. As you see here, first of all, we took the total number of elementary and kindergarten teachers, which was 16,000, and then we divide them into 3 categories. Kindergarten teachers, we took 257, and elementary female teachers and elementary male teachers. Then we divide each category into these cities, the 4 cities, proportionally based on how much the portion of the city itself. A team of data collectors collected the data using self-administered questionnaire, which was published and validated in another study. The questionnaire contains 12 questions regarding socioeconomic characteristics and 38 questions regarding the tool. They are divided into 3 subscales. The first one is about symptoms and diagnosis, and the second one is about the general information about ADHD, and the later one is about the management practices of ADHD. Data were entered and analyzed using SBS version 22. First of all, the total sample was 1,095 teachers. The mean knowledge, we examined them as there is correct answer and incorrect answer, and there is a total score. And their knowledge about ADHD was, the mean was 21, and the level of perception was 76. We mean perception by that, that we divided the answers into correct answers. We say they are knowledgeable, incorrect answer, misperception. And if they say, I don't know, this is lack of knowledge. So teachers were aware mostly about symptoms. 88% were aware, they are knowledgeable. However, there is a great lack of knowledge, about 90% and 77% in general information and treatment or management practices, respectively. This magnifies the importance of future education programs should focus more on these 2 aspects other than the symptoms. Also, teachers who said that they got enough information regarding ADHD during their undergraduate study or their college, they scored higher, as you see, 63% as a mean of knowledge, while they who said they didn't get enough information scored lower. However, only 59% or 60% of the teachers did not get enough information about ADHD. Teachers who are in kindergarten specialty scored higher, and teachers who have been asked to diagnose or teach ADHD students scored higher. This magnifies the importance of exposure as a part of the educational programs. Also, we asked about the sources, the main sources of ADHD, about teachers, if they got enough information, if they got the information or read about ADHD, what are the main sources, and scientific studies and books were the highest mean of knowledge. We asked teachers if they had been in a conference or in a workshop. Teachers who were in or attended workshops scored higher by 64%, higher than the others by 55%. This highlights the importance of workshops for the current teachers. So our conclusion, teachers who have higher qualification or training in identifying ADHD significantly scored higher in our study. Therefore, implementing educational program and workshops based on the books and scientific study would be highly effective and cost-effective and recommended. In addition, future education programs should focus more on the subscale regarding general information and regarding the management practices of ADHD. That's all. These are our resources, and thank you. Any question? تفضل.
Assalamu alaikum. First of all, thank you for this great, informative, comprehensive presentation. I'm very proud that once a time that you are, Sami, one of my dear students. My question that impulsivity and inattention and hyperactivity and delayed speech, all these characters are not, one of my relatives who have experience, diagnosed as an autism. Mm-hmm. Is there a relation between ADHD and autism?
There is a relation between autism and ADHD. However, ADHD is different and is characterized by inattention, a triad of inattention and hyperactivity and impulsivity in اندفاعية. While autism is related to التخاطب أو مشاكل في التخاطب مع اللغوية أو غير اللغوية، ويكون اتجاه له كرايتيريا ثانية غير عن ال ADHD. ال ADHD مسار الثاني يعني. Any other question? تفضل.
Thank you for the great presentation. Can you highlight us if there are any effect for hereditary factors in ADHD?
Yeah, it is hereditary, but it is not like if we say thalassemia. If the father and mother are married and they have the genes, they will get surely they will get thalassemia or sickle cell anemia. But ADHD, we don't know what are the factors or the genetic factors, but it is kind of related in a broad spectrum in genetic, as a hereditary, not as a genetic or.
What about relative marriage? Is there any effect for relative marriage in the ADHD?
No, as far as I know, there is no effect of relative marriage. It is either the father has the symptoms or the mother, and you would, if you have an ADHD child, you would ask about symptoms of the triad to one of the parents, then you may find that there is some hereditary link, but there is no specific genetic regarding ADHD.
Thank you. I would like to remind the audience that the subject of this presentation is a knowledge of teachers about ADHD, not about ADHD as a subject in per se.
تفضل.
السلام عليكم ورحمة الله وبركاته. طبعا اللغة أنا ما فهمت إلا شيء قليل.
ما عندنا وقت عشان
طبعا
الإنجليش.
طبعا أنا سؤالي الحل والعلاج في العينة اللي أنتم استخدمتوها في دراسة البحث، هل في حلول مطروحة أو الحل اللي أنتم تسعون له بعد هذا البحث في نوع مزدوج؟ لأن الأدوية عندنا في العيادات المصروفة يكون جانب علاجي في الجانب الطبي، وفي قسم علم النفس نسعى إلى الجانب السلوكي، العلاج المعرفي السلوكي. فهل فيه اتفاق بين الاثنين أو على نفس العينة طبق نفس الاتجاهين للبحث عن حلول لهذا الاضطراب، بحيث أن هذا الاضطراب أساساً مسيطر على أغلبية الأطفال الموجودين من عمر 6 سنوات حتى سن البلوغ؟
Of course, we didn't ask exactly about what are about the difference between treatment as a medication and the treatment as cognitive behavioral therapy. But our research was, as the doctor mentioned, about the knowledge of teachers about ADHD. So we assume that if they know better, they would diagnose ADHD early, and this would greatly affect the child and will minimum his difficulty in learning, other associated symptoms, and will make him normal. We asked them about what do you think the management practices if you have an ADHD student and the treatment. So we asked them is there a treatment, is there a medication? The vast majority, sorry, you asked me in Arabic. We asked them if the vast majority, the vast majority they didn't know like there is a medication for this disease. This is one thing, and also we asked them about their role. Are they involved? And the vast majority said yeah, about like 85%. They said yeah, we have a role in the management in the class. So our questions about the management practices like these questions. طبعا أنا قلت إنه إحنا ما سألنا عن الأدوية إيش هي بالضبط، ولا هو العلاج السلوكي إيش هو بالضبط. سألنا إيش تعرف أنت كتيتشر كمعلم عن مثلا العلاج، هل له علاج ولا لا؟ الأغلبية كانوا ما يعرفون إنه علاج، فكانوا يقولون لا ما له علاج هذا، فهذا ممكن يعطي معلومات خاطئة للآباء أو إنه ممكن ما يعتقد إنه في علاج لها. إضافة إن سألنا إيش الأساليب اللي ممكن تستخدمها أثناء يكون عندك طفل فرط حركة، إيش راح تسوي معه؟ هل راح تحوله؟ كيف تتعامل معه؟ هل راح تضربه؟ إذا شفته يتحرك كثير يسأل كثير هل راح تعاقبه ولا تكون مرن معه أكثر من غيره وتعرف إنه هذا حالة خاصة وإنه عنده فرط حركة؟ مثل هذه الأسئلة كانت أسئلتنا، لكن ما سألنا إذا هو عن فعالية الأدوية أو فعالية السلوكي، وهذا ممكن في الأبحاث المستقبلية ممكن تسوي مثل هذه الأبحاث اللي تقارن بين الأدوية والعلاج السلوكي في أطفال يعني اللي عندهم فرط حركة. يعطيك العافية. شكرا لكم.
Bismillah ar-Rahman ar-Rahim. Good morning, everyone. I'm very happy to be today a presenter with you. For those who don't know me, my name is Fawziya Alaouid. I am a graduate student from King Saud bin Abdulaziz University. I have a public health master student. And today I'm going to present my topic, which is about the effect of mobile health application on modifying the major behavior factors of non-communicable diseases among Saudi female adults in Qassim. Okay, so, sorry for that. Okay, so I will be starting with the introduction, and then I will move on for the methodology, and then after that I will discuss my results that I have found, and then I will be concluding. So I'm very sure that every one of you have came to know, even in the family, or contacted or experienced someone with non-communicable diseases. And also, it's not only called non-communicable diseases, but also it's called chronic diseases, which is one of the major 4 categories, either cardiovascular disease, or diabetes mellitus, or chronic respiratory disease, or even cancers. So the fact that I want to highlight today is, do you know that it's responsible for 40 million deaths annually? And also, not only that, but 15 million of them among people who aged 30 to 69 years old, which is a younger age group. Also, all of these 4 major categories of non-communicable diseases shared the same major behavioral risk factors, which is lack of physical activity and also unhealthy diet, smoking, and excessive use of alcohol. The uniqueness of our study is that we used the massive proliferation of mobile health applications utilization, especially that all mobile users have at least 1 mobile health applications in their cell phone downloaded. So the rationale behind our study, our aim was to explore how mobile health application can contribute in the promotion of healthy behaviors and prevention of non-communicable diseases, especially major behavioral risk factors among Saudi female adults. Now, the objective, we assessed 3 things, 3 domains, the knowledge level, the health beliefs, and health behaviors for those non-communicable diseases, major behavioral factors. And also, we measured the % change of mobile health applications. When they use the mobile health applications, how effective in modifying them, the behavioral risk factors, especially regarding weight loss, improving their healthy diet, and physical activity. Now, the methodology here, we used a quasi-experimental study designs. It's a pre- and post-interventional study design. Now, first of all, we defined the study population, which was adults from 20 to 39 years old females, and we selected the subjects. It's in a non-randomized way. Sorry for that. It's in a non-randomized way. And then with the certain inclusion criteria and the study setting, we choose 2 settings, but in a randomized way. For the primary health care, we choose 8 primary health cares among 32 primary health cares in Qassim. And also we choose 1 hospital, which is BCH, among 3 main hospitals. And all of that in a randomized way. Our sample size was 402, the total sample size, and then we divided them according to their willingness to participate, either in the intervention group or in the study group. So in the intervention group was 134, whereas in the control group was 268. What we did actually is we first distributed the informed consent, and we obtained the pre-test, and then after that we given for both groups a lecture for 45 minutes regarding NCD's risk factor. And then after that, for the control group, we collected already in the same session the post-test, Whereas for the intervention group, we distributed the mobile health application also with full training for self-utilization at home. And then we given a period of 2 months, and we did the follow-up along with SMS messages. And then after that, they came and they were given the post-test. So the sample size, as I said, according to what we choose the sample size, it's basically we choose it according to a previous study, which said it uses the same concept, mobile health application, but in a different way. It used it in the treatment of diabetes patients, and it was 61% the prevalence, and we calculated, finally, it was 402. Now, the inclusion criteria, we have chosen those who were Saudi, 20 to 39 years old, and educated, and also who has or possessed a mobile phone, so that with the criteria, internet capabilities, and also SMS features. Now, how we collected the data, it's based on 2 things. Basically, it's first of all, it's pre-validated in a study done 2017 in the same context, in our context in Saudi Arabia, and also it measures 4 things, as I said: knowledge, health behaviors, health beliefs, and also the socio-demographic data. Whereas in the mobile health, we use the surveys through the mobile health application. Now, the data management, data from the pre-test and post-test were cleaned, filtered, and entered in the SPSS, and we did the chi-square just to measure the significance, which is below 0.05, and also we use the binary logistic regression to check only for the association between factors. Now, here, as you can see, the results. Here, the most categories were 37.7, almost 38, 30 to 34, which means it's younger age group. And most of them, they were holding university level. And also, most of them, half of them with normal weight, and half obese and also overweight. Now here, in the pre-test, baseline in the pre-test knowledge, as you can see, the overall knowledge there were no variation, not significant. Regarding the NCD's burden, NCD's behavior risk factors, and we ask about the NCD's fatality and also the NCD's term or concepts. Whereas in the post-test, as you see, there is a strong significance in the post-test regarding the overall knowledge. Same as for health beliefs. But for the time limit, I didn't post it, but the same results we got. For the health behaviors, as you can see, there's a strong, significant variation between the 2 groups, especially also for the intervention group pre and post. Now, also, this is as you can see, this is a survey through the mobile health application. Basically, we measured 3 things. We measured the BMI categories. We measured also the physical activity forms, what type of forms they are practicing, and also the dietary habits. All of them, they were significant in the post-intervention after they used the mobile health application for 2 months compared to the pre-test. Now, in the binary logistic regression, those who were younger age group, they were 2 times more likely to be knowledgeable compared to the one who was 35 and more. And those who were holding primary level, they were less knowledgeable compared to the university, which seems realistic. And also, those who were obese, they were less likely to have good knowledge compared to the one who was normal weight. Same for the health beliefs and health behaviors. So in order to conclude, first of all, let me say that our results is in line with other authors. Chan et al., he said the same things regarding the age. He said those who were adolescents, they were same, they have less likely knowledge, whereas in the younger age group, similar, more likely. So in order to conclude, we can say that mobile health application is effective for health promotion and lifestyle modification, and combination of mobile health application along with SMS features and was the most beneficial methods. And we need continued commitment of political stakeholders and governmental support in the advancement research regarding the mobile health application. So thank you. Any question? Yeah. Go ahead, please.
Okay. Assalamu alaikum. Thank you very much for this nice presentation, and as well as the merit of the topic. It's actually touch our daily life and how to modify the risk factor. I have a few concerns about your study. Why you focus on female only?
Yeah. To answer you, first of all, I am a female. So due to the cultural sensitivity, you know, I'm dealing with females. This is one thing. Second thing, that the prevalent, as Dr. Sorry, for that, I think Farid, or he discussed the prevalence among female was 65%, especially in the behavioral risk factors, more than male, regarding the physical activity, healthy diet, and weight, and the obesity. So for sure, I will focus more on female since I am female also.
Okay. About the apps itself, does it, what you call it, categorize or make special instruction for the audiences or the participant how to, what you call it, follow the weight and do some exercise or something?
Yeah.
Because we are lacking the knowledge about the apps itself.
Sure.
Okay.
So for the mobile health application, as I said earlier, first we sat with them and we discussed how to fully utilize them at home alone without assistance. And second thing, I said, if you just bear with me, that I did mention that we followed them for 2 months with the SMS, along with the mobile health application itself, and with the phone calls that is bi-monthly, so for 2 times. These obstacles, so we managed. It wasn't that much.
Okay.
Thank you so much, really, for your questions.
Thank you for the nice presentation.
Thank you so much.
You wrote here, or you told us that you followed the cases for 2 months only.
Yeah.
Do you think 2 months is enough time for a study like that?
Excellent question. I guess if you would just allow me, it is behavior. This is one of the limitations that I want to talk about, but due to the time limitation and the instructions. So one of the limitations is since it's a behavioral change, so it was difficult to just assume that this is the correct thing, because we need a long time since it's a behavioral. So this is one of the limitations that due to the time, one-time intervention, we cannot say it's 100%, but we are trying, and we are suggesting for more future research for that one.
طيب, you depend in this research, you depend on the questionnaire. Is it the ideal method for a study like that? Or
No.
you prefer to use more?
It's not only a questionnaire. I did say 2 things. A questionnaire and the database of the surveys of mobile health applications. So 2 things we used.
You think it is enough? Or
what do you suggest?
You recommend more research about this?
Okay, I did, yes, correct. I said for the suggestion for future research, we are recommending more research on, especially in the concepts mobile health application. Thank you really for your questions.
Thank you very much for the presentation. I would like to ask whether how do you reach the conclusion that these effects are solely due to the application of the mobile? In other words, you did not manage the confounders in your study. How did you manage your confounders? These population are educated populations. They may log on to the internet. They may have other knowledge to push them to manage their lifestyle more, and then controlling it. How did you manage it?
Because since we use the pre and post test for the intervention group, We measured in the pre-test, in the pre-surveys of mobile health application, we did measure the body weight and everything. So in the post-test, after 2 months of using the application, for sure there is a differentiation between the pre and post. So I think it's enough to say that there is an effectiveness of mobile health applications, since also there is a previous studies supporting the idea that it is effective. And you know, MOH, they are using the mobile health application already in the treatment and management intervention, rather than in the prevention domain. So, do you think it's not effective?
Can I comment on that, please?
Yeah, sure.
So I think actually, first of all, I will congratulate you. It was an applied research, not just for the sake of academic research. Very important, topic. Yeah. And I was really happy to see that mobile apps actually work. And I think they do. So I think regarding the last question, I am convinced that you have enough measures in your study, like the binary logistic regression. So not all, but most of the confounding effects were probably controlled. I'm not sure about the details, but you know. But my observation was that at the baseline also, I think that your intervention group was a little better in terms of like knowledge. That was one thing which I would look at it. The second thing I would like to point out is that you probably have enough data and you can probably go through it again and see in more detail like which specific factors of your intervention were more effective, you know?
Yeah.
But I think my concern will be only that how to apply that. So now you have done the research, now how can you take it like on a larger scale?
Yeah.
Can you make it a part of an intervention at the primary healthcare centers or not? Then only it will be effective. Thank you.
Yes. And let me tell one point, that there is a suggestion for MOH along with telecom companies to incorporate and to support this one on the community level. So we are trying hard to make it more effective and efficient. Thank you so much for everyone.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everybody. My name is Shaima. I am a fourth year medical student and a co-author in this research. Today, I will be presenting this research on behalf of Dr. Ubayma, the principal author. But before I will start, me and my team would like to thank the Regional Ethical Committee and the people who accepted our research and allowed to us for representing at the symposium. Now, I'm very proud to present our research in front of you. In hospital mortality في acute coronary syndrome in elderly patient. In the beginning, coronary artery disease is a leading cause of death. WHO reported that coronary artery disease in Saudi Arabia is around 24% of total of death, and that which ranked Saudi Arabia in 34th in the world. Acute coronary syndrome is a common clinical presentation of coronary artery disease and which associated with significant hospitalization, emergency visit, and death. Multiple studies showed that older age is a significant predictor of hospital mortality death, and poor clinical outcome for patients with acute coronary syndrome. Although patients older than 65 years old are encountering around 60% of hospitalization for acute coronary syndrome, the exact incidence rate of acute coronary syndrome in patients older than 75 years is not well known. The therapy for acute coronary syndrome is suboptimal in elderly patients. In addition, they have more risk for medical and procedure complication. In our country, there is no study investigated in hospital mortality of acute coronary syndrome in patients older than 75 years. So, our aim of study is to analyze the mortality and the predictor of death in patients older than 75 years and to compare the outcome between interventional and the non-interventional management in this age of group. For sample and study design, this study was retrospective design in period between January of 2016 to January of 2018, and our inclusion criteria is all patients older than 75 years with definitive diagnosis as acute coronary syndrome, including ST segment and non-ST segment elevation and unstable angina. For method and analysis, we screened all patients who admitted to Prince Sultan Cardiac Center in القصيم region, diagnosed as acute coronary syndrome in period between 2016 to 2018, and we found that a total of 2,940 patients. All patients younger than 75 years was excluded, so only 179 patients was remained, which is represented as 6% of total of patients. Then we reported the demographic data, a laboratory investigation, a hospital stay and mortality, and an electrocardiogram, an echocardiogram, a coronary angiograph, and the angioplasty. For analysis, we used two samples of t-test for normally distributed continuous variables between patients who survived versus death patient, and to compare between the outcome of interventional and non-interventional group. The results show a clinical baseline characteristic, a total of 179 of patients. Their mean age was 79 years, and the male gender representing as 72% of total of patients. A patient who diagnosed with ST segment elevation myocardial infarction represented 57% of the patient, in front of 43% of patients diagnosed with non-ST segment elevation or unstable angina. This table shows the most important clinical baseline characteristic, and we found 52% of patients had BCI, around 23% of patients had left main stenosis, 3 vessel disease, 34 of patients diagnosed as significant valvular disease, and around 8% of patients had intubation. CAG done in around 70% of the patients, and the results show 24% of patients had 1 vessel disease, and 16% of patients diagnosed as 2 vessel disease, while 23% of patients had 3 vessel disease with left main stenosis. There remains around 7% non-significant stenosis, while 30% of total of the patients had CAG. Out of 70% of patients who had CAG, 52% of the patients had BCI. During hospitalization, 12% of patients died. We use a T-sample test to give us an association with in-hospital mortality, and we found that age, non-ST segment elevation, ejection fraction, left main artery stenosis and or three-vessel disease, patient significant valvular disease, intubated patient who had positive creatinine kinase, patient who had cardiac shock or complete heart block. All of these variables are significant associated with in-hospital mortality. Then we run all of these variables in univariate and multivariate regression, including all variables significantly associated with in-hospital death. In univariate regression, we found that age, creatinine kinase, intubated patient, and high creatinine level, all of these variables are significant predictor of in-hospital mortality. Then we run a multivariate regression on all of these significant predictor of death, and we found that age, creatinine kinase, intubation are the most stronger significant predictor of in-hospital death. In conclusion, 6% of patient hospitalization for acute coronary syndrome are older than 75 years. Mortality rate of acute coronary syndrome in this age of group patient around 12%. Age, a high cardiac enzyme at the same time of presentation and need for mechanical ventilation support are a significant predictor of hospital mortality. No survival benefit were shown with the primary or early BCI in elderly patients presented with acute coronary syndrome when we compare to a medical treatment. For decision of performing a BCI should be taken in consideration of age as well as associated comorbid disease and the hemodynamic state. Further randomization prospective study are requested to assess revascularization versus optimal medical management of acute coronary syndrome in patients older than 75 years. And this is our reference. And thank you. Any question? Any question?
Assalamu alaikum.
Alaikum assalam.
Thank you, Dr. Shaima, for this interesting topic. But just I have one comment. You mentioned something about the creatine kinase. Is it, yes, it's creatine kinase, not creatinine kinase.
Maybe I missed that one.
Okay?
Yeah.
Okay, thank you.
Sorry. Thank you for your comment, doctor. Thank you for your time. Yes, doctor?
Thank you for the nice presentation. You did not mention the heart failure as a predictor of death. And you did not mention the cause for intubation. Why the case of coronary syndrome or acute coronary syndrome or angina or unstable angina or MI, why it needs intubation? You should mention the relation between the intubation and the cause, which is the acute coronary syndrome. What is the relation between the intubation and the acute coronary syndrome? What is the relation? The relation is the heart failure. You have to mention the heart failure. You did not mention heart failure at all. This study lacking the heart failure as a predictor of death. You should, next time, or you recommend another research to include the heart failure as a predictor of death, which needed the intubation. Intubation is because of heart failure. You did not mention heart failure at all. Thank you.
Thank you for your point, doctor. Thank you. Any question more? Thank you for your attention.
investigate the role of reactive oxygen species damage histone H2A in the onset of autoimmunity in patients with systemic lupus erythematosus. In this study, the commercially available histone H2A was exposed to hydroxyl radicals, which were generated by UV irradiation of hydrogen peroxide, and the modified product was characterized by physicochemical techniques. As far as the antigenicity is concerned, which was probed by inducing polyclonal antibodies in experimental animal. For that, we use rabbits. Specificities of induced antibodies were evaluated by their binding to various blood proteins, nucleic acid, and their ROS modified conformers. In order to assess the possible role of hydroxyl radical modified epitopes on histone H2A in the etiology of autoimmune diseases, we have selected SLE patients for that. This is the UV absorption spectra of native histone H2A and ROS modified histone H2A. You just see the hyperchromicity at 280 nanometer that gives 100% confirmation that the hydroxyl radicals generated by UV irradiation of hydrogen peroxide cause extensive damage to histone H2A. These structural modifications were further confirmed by sodium dodecyl sulfate polyacrylamide gel electrophoresis. You can see in this gel, lane 1 and lane 4 contains the SDS molecular weight markers, whereas lane 2 and lane 3 contains native histone H2A and ROS modified histone H2A respectively. You just see the band intensity in lane 2 and lane 3 that gives a clear-cut indication that hydroxyl radical caused extensive damage to the protein. Carbonyl content is so far considered to be the most reliable marker for measuring the protein oxidation. For this reason, the experiment in this figure was conducted. As you can see, the difference in the carbonyl formation or carbonyl content in bar 1 and bar 2. Bar 1 represents for native histone H2A and bar 2 represents for reactive oxygen species modified histone H2A. That gives a clear-cut indication that hydroxyl radicals caused extensive damage to the protein. As far as the generation of hydroxyl radical in the reaction mixture was concerned, which was determined by mannitol and DMSO, as they are very well-known quenchers, or we simply call it inhibitors, for the generation of hydroxyl radicals. So as you can see in bar 3 and bar 4, by the addition of mannitol and DMSO, the carbonyl content significantly decreased. So this gives 100% confirmation that the damaging agent in the reaction mixture was hydroxyl radicals. This table summarizes the complete characterization of native and ROS modified histone H2A under identical experimental condition. You just see the modification section of this table, 41% hyperchromicity at 280 nanometer and 73.3% loss of the tryptophan fluorescence intensity when the protein were excited at 295 nanometer. And these structural changes in the protein by tryptophan was further confirmed when we excite the protein at 280 nanometer. As you can see, the reduction in the fluorescence intensity by 74.9%. 52.1% loss of the band intensity on SDS page, as I already showed, 80.9% increase in the carbonyl contents. So all these parameters clearly indicating that hydroxyl radicals cause extensive damage to histone H2A. As far as the antigenicity is concerned, antigenicity of native and the modified histone H2A was probed by inducing polyclonal antibodies in rabbits. For that, we immunized rabbits with histone H2A and ROS modified histone H2A. This is the visual. This experiment was done for the visual detection of antigen-antibody interaction. As you can see in immunodiffusion, figure A represents for native histone H2A, and figure B represents for ROS-modified histone H2A. Here, in the central well contains the antigen alone, and from well 1 to 6 contains the serum samples that we obtained from the immunized rabbit. The lane 1 contains neat, while lane 2, 1:2, 1:4, 1:8, 1:16, and 1:32 diluted immune sera that we obtained from the immunized rabbits. And the precipitant line between the well clearly indicates that the antibodies raised inside the rabbits are highly immunogenic or antigenic against their respective antigens. This is the elution profile of anti-ROS histone H2A IgG on protein A agarose column. The single peak and a single band on sodium dodecyl sulfate polyacrylamide gel electrophoresis clearly indicates that the IgG from the immune sera from the rabbits were highly purified. We also isolate IgG from the immune sera from those rabbits where we inject the histone H2A, and the results were almost same as you have seen here. Again, for visual detection, we perform gel retardation assay. This is the assay through which we can determine the formation of immune complexes. As you can see in this gel, the lane 1 contains antigen alone, which is ROS-modified histone H2A, and lane 6 contains the IgG alone, which is the affinity purified IgG that we isolate from protein A affinity column. And from lane 2 to 5 contains same amount of antigen with increasing amount of IgG. This will lead to the formation of immune complexes, as you can see in the top of the wells. That is, these are immune complexes, and this cause the reduction in the band intensity of unbound antigen, as you can see in the base of this gel. So this gives 100% confirmation that the antibodies that we generated inside the rabbits are highly immunogenic, and they are highly specific for their antigen. As far as the antigen binding specificity is concerned, which was determined by various blood proteins and nucleic acid antigen and their ROS modified conformers. As you can see, again the ROS histone H2A was found to be significantly inhibited, which was 94.3%. That gives again indication that the antibodies were highly specific, and these antibodies also shows cross reaction with native histone H2A, calf thymus double stranded DNA, ROS modified calf thymus double stranded DNA, single stranded DNA, and ROS modified single stranded DNA, and also show some binding with mitochondrial DNA. In order to assess the possible role of ROS-modified epitopes in the etiology of autoimmune diseases, the sera from various SLE patients were studied for their recognition of native and ROS-modified histone H2A. This is the direct binding ELISA of 1:100 diluted SLE serum samples. You just see the difference in bar 1 and bar 2. Bar 1 represents for histone H2A, and bar 2 represents for histone H2A. You just see the difference in the recognition of antibodies from SLE patient. ROS modified histone was found to be significantly recognized by these antibodies, where native DNA we used in this case as a positive control for SLE patients. To determine more about the specificity of SLE antibodies towards ROS modified histone H2A, we perform the competitive binding assay. You just see the mean plus minus SD values in this figure. 51.6% for ROS modified histone H2A, and 32.9% of the for native histone. So this gives a clear-cut indication that antibodies from the SLE patient recognizes ROS modified HSA in a greater extent as compared to native histone H2A, where native calf thymus double-stranded DNA was used as a positive control for SLE patients. Again, for visual detection between antigen-antibody interaction, we perform the gel retardation assay, or we simply call it band-chipped assay with affinity purified SLE IgG. As you can see in this figure, the lane 1 contains the antigen alone, which is ROS modified histone H2A, and lane 6 contains the IgG alone, which is affinity purified IgG from SLE patient, and from lane 2 to 5 contains same amount of antigen with increasing amount of IgG. This will lead to the formation of immune complexes, as you can see in the top of the well, which causes the retardation in the band intensity of unbound antigen. So this gives 100% confirmation that the antibodies from SLE patient recognizes reactive oxygen species modified histone H2A. This is the final study. This is the first study from the globe that shows the role of ROS modified histone H2A in patients with systemic lupus erythematosus. This study provides an important insight into the immunological basis of autoantibodies generation in patients with systemic lupus erythematosus. And finally, we thank the funding from King Abdulaziz City for Science and Technology. We also thank Mr. Hamad Al-Hamad for providing SLE patient samples, and I personally thank Casimiro Victoria for technical assistance. Thank you very much. Any question? Dr. Walid, question? Any question, please?
Thank you for the nice presentation. It was a good presentation, actually. But I want to ask you only one question.
Yes, please.
Why it is experimental? Could it be done on humans? I think it is better to do it on humans because we have many cases of SLE, and we need to explore the effect in humans, not in rabbits. Why experimental?
No. We only raised antibodies in rabbit just to show the antigenicity of the ROS modified histone H2A. As far as the humans are concerned, we have collected the samples from the humans. They are SLE patients that we have tested already. But of course, the study need to be, and we have done the things on humans here. Yes, please.
Thanks, Dr. Zohar, for this innovative study. How do you confirm the cross-reactivity of immunoglobulins between patients of SLE with rabbit samples?
Yes.
And the patients of SLE all are not in the same disease activity, of course. So maybe they're having lower or higher level of antigens that may not be detected by the method used. How do you guarantee that?
Yeah. This is a very good question. Actually, SLE patient contains a series of antibodies that were generated against different antigens. The antibodies we raised in rabbit that shows the cross reaction with some other antigen. We just try to show that the antibodies which are present inside the SLE patient, they are not specifically from this specific antigen. They may have generated by by the action of some other antigens. Okay, so for this reason, we performed the cross-reactivity experiment. As far as the antigens are concerned, we make ourselves the different ROS-modified antigens. We use different blood proteins, nucleic acid antigens, single-stranded, double-stranded. So we just try to show that through the cross-reaction of antibodies that we raised, that these antibodies are not specifically only against the ROS-modified histone H2A. They may have some cross-reaction with some other antigens. Any question, please? Any question, please?
Assalamu alaikum.
Yes, please.
Here, on this side. Thank you for a very nice paper, and I would like to ask you about the sample that you took from patients.
Yes.
Are they all definite SLE patients, or do you have any probable diagnosis or other?
Yeah, we have collected these SLE serum samples from the serology lab of Brother Central Hospital. And from our side, we confirm whether the serum samples belongs to SLE group or not. For that reason, if you see my presentation, I always used double-stranded DNA antibodies, so which is a hallmark for SLE. Okay, so all SLE patients we have included that contains a positive test for dsDNA. Okay.
Many thanks to Dr. Zafar.
Yes,
excellent as usual. Well done. I had just one idea. Did you think of utilizing or inducing or making SLE models utilizing these modified antigens?
100%. Actually, this study has great importance for the drug designing. But the question arises what the drug designer will do. Drugs designer, actually they will do epitope mapping. The epitope, the region that was generated by the hydroxyl radicals on histone H2A. Once they got to know the actual altered amino acid sequence in that region, then they will try to neutralize the antibody generation against it by many modern techniques like monoclonal antibody therapy, or by making small inhibitors or pharmacological agents that will neutralize the effect of these epitopes through which the autoantibodies are generated.
Yeah, we have one more question from upstairs.
Any question, please?
Assalamu alaikum, Dr. Zafar.
Yes, please.
Dr. Zafar, just I want to make sure that these patients of SLE samples were from different stages SLE patients or from only one stage, as we are histopathologically staging the patients. And even the antibodies and the response to these antibodies, I think it will be different. Are you already using different titrations for these autoantibodies, for these antibodies from histones? This is the first question. Second question, I think that from your study, I concluded that we can make use of antioxidants as a treatment options for patients of SLE. Is it possible for this? Or
yes,
no?
yes.
Thank you.
You are asking a very good question. The answer of your first question is we have not characterized ourselves the level of on the basis of severity. Okay, we characterize SLE patient only on the basis of the positive test for anti-double-stranded DNA. Okay, and the answer for your what is your next question, please?
The next question was about the usage of
yes.
Thank you.
Antioxidant therapy may be very useful because many authors I remember the name of one author, Escofield, which is who is working in California University. He already mentioned in his papers that antioxidant therapy will be the best one for these patients. Yes, please.
Assalamu alaikum. Thank you for this nice presentation. My question is, introduction of stem cells with addition of melatonin can enhance regeneration and protective value against ROS. Yani, I think in melatonin will enhance the stem cells and could be used in
actually
of,
for my study, stem cell relation, no relation with the stem cells. Okay. Any other question, please? Dr. Walid? Okay, thank you very much.